Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Subscribe now and stay on the forefront of the digital healthcare revolution.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civitaris, and today I'm joined by Dr. Dan Durand, MD, Chief Medical Officer at Prenuvo, the world's largest and most advanced network of clinics exclusively dedicated to proactive whole-body MRI for early-stage disease detection. Before joining Prenuvo, Dr. Durand served as Chief Clinical Officer and System-Wide Chair of Radiology at LifeBridge Health. During his tenure, he was instrumental in establishing the LifeBridge Health clinically integrated network, overseeing the care of over 150,000 individuals through value-based contracts. Prior, he held leadership roles with Johns Hopkins Medicine and Evolent Health, and worked as a consultant with McKinsey & Company. Dr. Durand also serves on the adjunct faculty of Stanford University and George Washington University. Dr. Durand, it's a pleasure to have you on the show. Welcome.
It's a pleasure to be here, Chris.
All right, so let's start with what led you to Prenuvo. Can you give us some background on your personal journey and then the overview of your role at the company?
Well, simply stated, I came to Prenuvo for the same reason I became a radiologist. And I became a radiologist and I chose that field because really imaging is where diagnosis happens in medicine. The vast majority of the most serious diagnoses all require some form of imaging. And really, it's often imaging that clinches the diagnosis or even raises it to begin with. But I'd seen in my career and my personal life, there are a lot of steps that come before imaging. And the question that Prenuvo poses, and many are posing right now, not just Prenuvo, is should we image sooner? And I had a career that was over a decade and did a lot of interesting things, as you've referenced. But really, it came down to the fact that I felt, yes, that really by bringing imaging forward and making it more accessible for patients, that we can vastly improve healthcare and vastly improve outcomes. I discovered Prenuvo as a company back in 2018. I became aware shortly after they incorporated what they were doing, and I was a very early fan and very intrigued. And I got to know the team better this past year, and then made the decision to come over and join full time.
It's interesting, and we talked a little bit about value-based care at the introduction, and obviously the industry has been pretty hyper-focused on value-based care for a number of years. And obviously, you have a tremendous amount of experience in that space as well. Curious your views on where a proactive MRI fits into that equation, or how it might compare to current healthcare models from your point of view.
Well, on the face of it, I think a lot of people would have skepticism because they look at MRI and they say it's costly. And so if you're doing more of it, you're adding to the cost of care. And that seems to be people's first impression. But I like to slow it down and say for a second, maybe not as straightforward as you think. And really, why is that? Well, we have a tremendous access crisis in healthcare today. And we also have a tremendous late diagnosis crisis in healthcare today. And those two things are definitely related to one another. Nobody knows exactly how much. So the idea of imaging earlier with whole body MRI as sort of the best way, I would argue, that you can image earlier. But the idea of imaging earlier is the idea that you catch disease extremely early, maybe even in its pre-symptomatic, earliest pre-chronic stages. And at that stage, intervention can prevent progression either to a catastrophic diagnosis that will be extremely expensive and extremely limiting in quality of life and sort of quality of life years lost. But also you can intervene early on things like fatty liver that can become a chronic set of issues that then sets up other health problems in a kind of cascade or domino effect. So I think it's not as easy as people think, because what we see in our practice is for a significant number of people, we find either early chronic diseases, things they can act on, or sometimes really serious stuff in the earliest stages. And sometimes, like everyone else, we do find really serious stuff in its later stages. But more frequently than not, when we find something very bad, it's in its early stages when the data tells us that the patients will have the best outcome if they intervene early. It'll be many years before we can sort of answer your question, right? Which is the obvious thing is you're doing extra. Any drug that's out there, we'll take GLP-1s, right? Anything that's out there, you can sort of get hung up on the cost, or you can stop for a second and say, wait a second, isn't this actually kind of something we've been looking for forever to solve a major problem we've been faced with? So in the case of GLP-1s, it's obesity and all the morbidity that drives. In the case of whole body MRI, it's things like cancer and many other conditions that just present too late when the damage has already been done to the inside of the body. And when you have symptoms and you can see it on the outside of the body, that's sometimes too late to get a good outcome. And I think in the next few years, we and others will study and see what the long-term impacts are. But I personally expect that that people will be surprised at how either cost neutral or actually beneficial this is to net total costs.
It's really interesting, and obviously, being a marketing major from a state school in New Jersey, my clinical background is about as limited as it gets. So help listeners like myself understand the list of conditions, abnormalities, things like that that MRIs can detect. Obviously, you alluded to a few of the really big ones, but how broad of a spectrum can preventative or proactive MRIs actually cover?
The reason MRIs are such a great modality is they offer really the best that radiology has in terms of characterizing tissues. So seeing really what is going on in the chemistry of a tissue, which then offers major clues as to whether the tissue is healthy or diseased, and if it's diseased, what type of disease is impacting it. MRIs do not use any ionizing radiation, so no cancer risk due to the scan that has ever been demonstrated or that we have any reason to think exists. So MRIs don't cause cancer, and they don't use the bad type of radiation, the ionizing radiation. The way we do MRI, we also don't use contrast. Now, contrast can have some diagnostic benefits. However, in the screening context, we choose not to use it for two reasons. Number one, we want our patients to be comfortable, and the idea that you can come to a Prenuvo center and get screened and not only not get any radiation, but also not even get a pinprick, not get an IV, not get anything injected into you. That's extremely attractive for many people. And then beyond that, the chemicals in MRI contrast, the risk is worth the benefit in certain instances. But if we can avoid them, we choose to, because they're on rare occasions, there have been shown to be things like allergic reactions to these chemicals.
Right.
And they're not chemicals that are normally found in the body. And so our philosophy at Prenuvo is we don't want to put them there if we don't have to. I'm just kind of starting with that's what MRI is, because you can compare it to other things like ultrasound or CT and X-ray, and it really is the most advanced modality and the most gentle in terms of the amount of information it can get for the amount of risk to which it exposes patients. Because it's so powerful, it can diagnose a tremendous number of things, well over 500 individual conditions. It kind of gets down to how much you're a lumper or a splitter, how much you want to take cancer and divide it in all the millions of different, well, not millions, but definitely thousands of different types of cancers that have been studied under microscopes over the years. Anything that grows in your body that doesn't belong there, once it gets to, let's say, 1 to 2 centimeters in size, you'll see it on MRI. And that means that you can diagnose any of those thousands of cancers potentially, right? Any type of infection that you get can result in what we call edema, swelling of different organs. It can result in patterns on MRI. So almost any infection can eventually, or even early on, be diagnosable by MRI. So MRI is not perfect for every single diagnosis, but I would argue for the majority of diagnoses that exist, there's a manifestation MRI can pick up on. And we believe, and I believe, it's the most comprehensive. What we're trying to do here is not come up with the one perfect test for everything you can have. We don't think that exists, or at least not today. Probably won't exist in my lifetime. But we want to come up with the one perfect scan that can partner with your annual physical exam, right? Your annual physical wellness appointment with your primary care doctor. The sort of best possible chemical, non-invasive auditing of what's going on beneath the skin surface, that you can know everything that's going on inside of you to a reasonable degree of certainty. That's what we're trying to develop, a comprehensive scan, and one that has no downsides in terms of getting an injection or getting exposure to radiation. And that's what the Prenuvo scan represents. Prenuvo's scan is to radiology what Dr. House is to internal medicine, right? There might be some things that a neurologist can get to quicker than Dr. House, but overall, he's really, really good. And that's what we're trying to do.
And you mentioned primary care and how this, fits into and integrates with that model and with that environment. Talk to me a little bit more about that. How do you envision the primary care setting being a part of this strategy of this new space, this emerging space? How does that fit together in your mind?
Well, I'll start by saying we are not trying to replace primary care. We're trying to supercharge it. We're trying to partner with primary care. And I'll also say that primary care is the single most important service a patient can get, right? Like you have to have a partner to go through the health system. And we love it when we have referrals from primary care, or when we have a patient come to us and their primary care doctor wants to talk with us and receive the information. We think that's incredibly powerful. We're not trying to replace your primary care, and we're not trying to replace any of the other consensus recommended screenings out there. The most well-known being colonoscopy and mammography, but there are others. We are an adjunct and added to that to achieve an even better outcome. And so the way we believe that this will work is primary care, it's super important, but it's under more and more pressures. That's why we've seen the emergence of the direct primary care model, where people pay a retainer. It's also called concierge medicine, where people pay a retainer their primary care doctor. Primary care doctors aren't doing this to become rich. They're doing this so that they can have a reasonable number of patients and not be constantly constrained in their interactions. So they can practice the type of medicine that they went to medical school to practice, if you talk with them. That is their motivation. And we think we are part of that equation, and we think we're part of this for any primary care doctor, but the forces that are causing direct primary care to emerge, are, very similar to, they're emblematic of what we're trying to help primary care doctors do. So in that visit, the primary care doctor, there's more and more for them to talk about because medical knowledge is expanding. It doubles, I think, like every year. And so primary care doctors have more they can diagnose and more treatments that they can use to help patients and more guidelines that they have to focus on. And their time is increasingly taken up by that. And they've always had this thing called the physical exam, which is important for the outside of the body. And you can tell a little bit about what's beneath the skin, honestly, but not much. And it's never been that scientific. And primary care doctors have less and less time to both learn this as an art amongst all the other things they're supposed to know, and also practice it in their constrained appointments. If they're in direct primary care, the concierge model, maybe they have a half an hour or an hour to interact with these patients. If they're in a general insurance model, they may have less than that.
Right.
And what we're trying to do is help them make sure they don't miss anything. Like we're a service. We're kind of like an outsourced service to look through the entire patient for them and make sure they're not missing anything and give them valuable information about what's inside their patient that they have no other way of knowing. The patients also like this, and that's, they come directly to us. That's a lot of our business, probably most of our business. And that's sort of the history of our company is a direct-to-consumer company. But our interaction with primary care is, I think, the future of the company. Because every patient in whom we find something, it helps us to have that primary care doctor to ensure that, that they're going to get where they need to go in the system. That's the way to think of us, is as supercharging primary care.
Yeah, it makes perfect sense. I mean, the notion of, arming, right, like my medical team with more information that's specific to me and what's happening in my body, that I can understand why that becomes just, an absolutely, kind of immediately appealing thing for patients and for, the primary care world as well. But you mentioned earlier that there are obviously some concerns with MRIs in terms of, you mentioned, patient anxiety around potentially radiation exposure and things like that. False positives, the need for more potentially randomized trials to prove the validity, all of that. So talk to me a little bit about what some of those concerns might be and how you envision moving patients, providers, and sort of the healthcare ecosystem as a whole beyond them.
Well, for the first one, on the radiation side, there is no concern. It's just misinformation. There
Right.
is not radiation exposure from the test itself, right? And so I think that's an important thing for people to realize. And maybe it makes them even a bigger fan of MRI in general versus other ways they can get things done. So I think that's pretty easily dealt with. In terms of false positives and false negatives, I think that there's healthy skepticism, right? But there's also a lot of similar misinformation and misunderstanding within the community.
Right.
So one of the things is, how do you define a false positive? Right? When someone's being imaged in the emergency room and we do a CT scan, which has significant, additional risks over an MRI, but is quicker to do, right? So there's the contrast often, and there's definitely the radiation, but they do them routinely and it makes sense in the emergency room. In that context, if somebody may have, let's say, appendicitis, and we do a scan really to focus and see if they have appendicitis, and we find other things that we didn't expect to find that then require someone to sort of work them up. Like, let's say we see a lung nodule. Those things are called incidentalomas, right? And they're called incidentalomas because you saw them incidentally. You weren't looking for them. In our method, and this is one of the quickest things people point to, they say incidentalomas and false positives. Those two things are two different things. We're going to talk about that. But the incidentalomas thing, when people apply that to screening MRI, it's another thing that I would just say is misunderstanding or misinformation. When you are looking for everything you can find to inform the patient about what's inside of them, and that's your purpose, and you're not in the middle of the night trying to figure out if they need surgery, right? There really are no incidentalomas. There are just findings. And some of these findings are informational. Hey, this person has a certain variant in their shoulder. We see this 5% of the time. They're different than most of the population, but it is not pathological. You can have one of those in almost any joint or any part of your body or in your circulation. So some of these things are informational, and some have to do with wear and tear that's expected. A lot of them actually do.
Right.
But just because it's expected, honestly, doesn't mean that it's not interesting to know about. And I can just say that from personal experience with my scan, it put to rest a couple of different points of anxiety I had about different lumps and bumps on my body that I was pretty sure were due to just wear and tear. But after the scan, I was 100% sure. And so I don't have to worry about that anymore. And people find that valuable. And it's a small thing. And it's not the main reason to get the scan, but it's additional value add. And you can't get it necessarily in a doctor's office. You can really just get a guess, right? Okay. And then we find things that are things that we might want to take action on, moderate findings that need further workup. So this is where the potential for false positive comes in, right? And depending again on how you define it. So let's say we see something, and this time let's say it's that lung nodule. Let's go back to that. And the lung nodule is large enough and concerning enough that it needs to be further imaged with a different modality. That's typically our next step. The lung nodule is a finding in this patient, right? And if they go through a different pathway or they get imaged somewhere else, this could come up. So we would argue it's worth knowing about, whether it's a significant size lung nodule or whether it's something in the patient's kidney or liver. These may be things in the latter instance, kidney and liver, the things we find there that are ultimately not concerning, tend to be more things people are born with, like cysts or things called hemangiomas, which are collections of blood vessels that look a little different. In the lung, it's typically due to a prior infection or some sort of inflammation. Usually it is not due to a cancer. But if they look a certain way, it becomes more likely, right? So our next step in most of these things is the patient gets further imaging, which again, we don't do. So why doesn't Prenuvo, why do we not do the next image, the next set? Because we want to be building our practice and our business on doing the screening. We don't want to be getting financially rewarded for true or false positives. We don't want to, because this is part of the issue, honestly, with healthcare in general. And I'm not pointing my finger at any given practice or hospital system, but there is this well-known phenomenon of what's called supplier-induced demand. And so by not working up these things and letting them go their usual course, which the health system is well equipped to do, we are avoiding the internal conflict of supplier-induced demand at Prenuvo. And it lets us really base our recommendations on what we think is going to yield the best outcomes for the patient. When they get followed up, the health system is going to figure out what this lesion is. And typically it just takes imaging, but sometimes it goes further than that. And in the studies we've done of our internal data, we have a very, very good record on if somebody's getting a biopsy at the end of this process. And again, we don't do that, but others do. It is usually worthwhile and usually winds up being positive. And that's not the case for all screening modalities. So we have our internal record shows a very good record on that. And we sort of reject the idea that if someone finds a mass in their body, whether it's in the lung or the kidney or the liver, and that gets characterized, if it winds up being benign, now they know they have this thing. Two things about that. Number one, if I have something like that, I want to know. Why do I want to know? Because if I get sick in the future, it could confuse the care team. That could wind up being biopsied if I'm in a different scenario and they don't have as much time to look at it. So now, hopefully, with little or no radiation, because the follow-up is, more often than not is recommended as an MRI. In the case of the lungs, it probably would be a low-dose CT. But we're letting the patient know what's inside of them for their future knowledge. The second thing is not all benign things are not dangerous. So something can be benign and not cancerous. And this is more common than people realize. But it can still either have a bleeding risk or another risk, or sometimes a risk that it becomes like it's a pre-malignant lesion that is benign but could become malignant. And so knowing where those are and what they look like is important. And the third thing is that if you have one of these lesions, because of that second tendency, we have this imaging on file. So then when they come back to us, or even if they go to somebody else in the future, it can then be measured so you can compare it and say, is this changing over time? Because things that are changing a lot that don't belong there, a lot of times a surgeon will decide to resect them. And that's not our decision, but we're making the information available so that surgeons and the other doctors can do what they think is appropriate for each lesion.
It's really interesting. Are you seeing, patients come back, I'll say routinely, for, these, preventative MRIs, these preventative scans? Or are you seeing it, I'm going to do this once as my baseline, and then sort of as I move through my life and my, healthcare journey, it becomes sort of a baseline of a snapshot in time that, future providers can sort of go back to and sort of compare to. My own curiosity sort of has me thinking about both of those scenarios. And I'd love your perspective on what you're seeing.
We are seeing more and more patients become return patients. It's obviously something that compounds over time. So our business has grown a lot. Our initial business in Vancouver has the highest return rate, and that makes sense. Those patients have been there, and that practice has been there for over a decade. But even if you just look online, and I'm not going to say names, but if you just look at notable people online who have endorsed us, you'll see that many of them are endorsing us this year because they went back their second time. And a subset of those are also saying like, hey, here was the benefit. Here was the benefit of the second time that I didn't get the first time. So the first time, a lot of it was around either something interesting was found, and again, I was none of these patients' doctors, and I've looked at none of their images. I don't do that. I look at images, but I don't look up, influencer images. That's not a thing. But there's some very well-known people that have said, hey, you found something and it saved my life. And Maria Menounos is probably the sort of litmus test for that, the most well-known example. But that was sort of year one. So there was a lot of people saying, hey, they found this, or I got really reassured. I did my first one and nothing's wrong. And now if you look, a lot of these very public folks are coming in for their second scan, and they're sharing either, hey, I continue to feel reassured, or some of them are saying, hey, we did a second look and this thing I had in me before has, changed or whatever. And now action's being taken. So I think the people and the patients speak for themselves on this, and absolutely two big trends this year. More return patients this year than last year, and more healthcare providers coming in choosing to be a patient themselves.
Interesting.
And more healthcare providers referring patients to us.
The proof's kind of in the pudding there. So I will be very honest. The first time that I heard about Prenuvo was via one of the, influencers out there, maybe the influencer out there who had a post on, I believe, her Instagram. But that's really interesting that physicians, the medical community, those that are, living and sort of breathing in the space, are coming to sort of the realization and the value that these types of tests can provide. You mentioned earlier too that one of the barriers is cost, and I want to go back to that. What steps are there that can be taken to make MRI diagnostics more affordable, accessible to a much broader population? Because the value, obviously, from a care perspective, seems so indisputable. If cost is a barrier, is there anything that we can be doing to lower those costs and make it more accessible for a broader population?
Well, I absolutely think that the Prenuvo model is more cost effective than any other whole body MRI that I'm aware of. And we've done more to make it available, and we'll continue to do that. So while you're accurate in the majority of the health system, we think of MRIs as costly, and we sort of restrict access to them, and that is a barrier. But Prenuvo is doing something very different in the sense that we are making it more widely available. And also by focusing on this specific type of exam, like anything else, we think it's a very important type of exam. And we're doing really nothing but 3 different versions of whole body MRI. That is all we do. That is all we do all day long in all our centers. And that's how you get good at something, how you get more efficient at it, and how you achieve economies of scale to eventually, through that scale, benefit the consumer. And our long-term goal is to make these as accessible as possible to everybody. People talk about us as potentially, sometimes we're mentioned, right, as being expensive. However, if you think about it, they're really talking about who's paying for it versus the actual expense. So in our instance, insurance is choosing not to cover. So, we take payment directly from patients. They can use their FSA and HSA to cover us to defray some of that cost. So it's not like all of it is post-tax. There are some tools they can use to make it less expensive. But at the end of the day, if you were to get the same exam done and paid for by insurance at some other place, we know it would be many times as expensive. So the real question that I like to put back is the question isn't so much why it costs what it does at Prenuvo. It's really how does it cost so little at Prenuvo? And the answer to that is because we've gotten very good at doing just this thing and focusing on it. And we want to continue to do that. And we want to continue to make it more accessible.
It's really interesting. Do you foresee, I know this is kind of a crystal ball question, but I have to imagine that Prenuvo, and I believe I read something like this in the research, that with more information, with more studies, with greater information at our fingertips, sort of across the medical community, you can kind of squint your eyes and see that this may on the horizon be something that insurance companies are going to sort of have to pay attention to. As more data becomes available in terms of the success of, preventing and catching diseases, earlier. And to your point, there seems to be a really potentially very clear ROI, return on investment, for not just, patients in terms of their health, but there seems to be a potential financial story here that could be really compelling to sort of the greater, lens of the healthcare ecosystem, isn't it?
Yeah, we think so. And we sort of eat our own pudding, right? Or in the sense that every Prenuvo employee has the option, certainly not the obligation, to get a scan if they like. So we are out there offering these to usually to employee and their family member, and they don't have to get them. Many choose to. I chose to. And so if this was really driving up costs, it would certainly be something we'd be experiencing directly. And so there is no company that's put more on the line, right, to sort of stand behind what we're saying than us, which is appropriate. Another company that's recently started a strategic alliance with us through a co-promotion is John Hancock. So John Hancock, the insurance company, is offering their Vitality members $500 off of a Prenuvo scan. And I think, look, what a great thing. It's really interesting to me that the first insurer that's choosing to work with us is actually the one that's most aligned, right, financially on patients living as long as possible and being as healthy as possible, right? Health insurers have to be a little more, careful, and I think, it'll take them longer, and they have to see maybe different source of evidence. But John Hancock has seen enough to sort of jump in there and do this, and we think they've been around for over a century, and they are deeply invested in their members living as long as possible. So their enthusiasm for us means a lot to us, and we think the rest of the insurance industry, outside of life insurance and health insurance and other forms of insurance, we expect to see them follow suit because we believe in the validity of what we're doing.
It's really interesting. And it's, I think we're contractually obligated to talk about AI and the impact of AI in the particular space. And obviously when it comes to, imaging and MRI specifically, the integration of AI is a real game changer. You and I have talked about this in previous conversations. So I'm curious, can you give us some more context around how AI and deep learning are affecting, what we can harness from an imaging perspective, and how it's improving, the capabilities in the space?
Well, the biggest way that we currently use AI is from our suppliers. So the folks that create the Prenuvo scanner, we have different suppliers, but we have one type of scanner that they create to spec. And these scanners have FDA approved AI that allows us to obtain the images at the same quality or better than we always have. But every year or so, with these extra algorithms, we can obtain them faster. And this is just great for patients for two reasons. Number one, it means a shorter scan time. And number two, it means that we can potentially add additional things in there with the extra scanner time that we have. We need to sort of balance those things. But it also means that somebody moves, we have more time to repeat a sequence and make sure the imaging is even higher quality. So that's, it might seem like it gets less press than the stuff that's reading it instead of a radiologist type thing.
Right.
But actually it's tremendously important. And it's probably the most transformative application of AI and deep learning that I've personally seen throughout the industry, but particularly at Prenuvo. Then elsewhere in the practice, we certainly have efforts where we're doing a lot of research with academic groups. For example, we have a collaborator group at Washington University in St. Louis, where we've been using Prenuvo developed AI to help look at our data sets and quantify different organs and different types of changes in different age groups to correlate things like the amount of visceral fat somebody has and then the age-related changes in their brain. And we found some really, I think, somewhat unexpectedly strong associations between visceral fat really driving a decline in neural volumes and probably by extension neural function. And so that's one example of how we're contributing to really understanding human biology better. And this is through the research applications of AI. Absolutely, in the future, we expect that there will be some action of AI on the interpretive side, and it will likely follow the same suit as you've seen in the rest of the industry, where it will be human in the loop, for the foreseeable future. But truthfully, like in the remote future, the type of scans that maybe we're doing in 5 or 10 or 15 years, if the right kind of apparatus is there to do this, you can imagine that we could obtain a lot of data at that point. And the human might be the bottleneck, right? Mm-hmm. So we definitely are always going to need radiologists, and we take great care of our radiologists, and we love our radiologists, but we may need to have to really do this in a super accessible fashion in the future. It may be that there needs to be sort of an upfront interpretive part or sifting of the data before the radiologist, provider at the end is sort of doing their thing. Because the amount of data points, we get 1.3 billion data points per patient right now. Every iteration of progress on the image acquisition side means we can either get more data or get that same amount in a smaller period of time. So what we're looking for, right, we're in this business because we think that maybe in the future we can do this in 10 or 20 minutes. And then, the price should go down, right? But you'll still be a set number of radiologists. And so even though that'll really contribute to demand for radiologists, it might be more demand than they can sort of satisfy, right? So we got to help them get through all that data and still have, a good sustainable career. If you look at some of the latest research in radiology around workload, radiologists are doing more and more because there's more demand, but there's a constrained number of radiologists. And that means they're having to review more and more studies, particularly in emergent settings. And so that ultimately, puts you in a space where there are some trade-offs and some concerns over, do they have enough time to look at all this and deliver high quality? We're not in that spot because we are doing this in a much more relaxed timeline. We have, more unconstrained turnaround times because they're outpatient exams and the patients are healthy. But it's something we're ultimately thinking about. Like, we want to continue to build a practice where the radiologists have the optimal tools and time to sift through all the data that they're given.
It's really interesting. And obviously, so much has been written about, the physician shortages that are, here and certainly going to be exacerbated as we move towards the horizon. So it's a really interesting, point that I had not considered either. So very interesting there. Anything else that you're excited about, that you're working on? Anything else that you want to share with the community as we wrap up here?
I think the thing that we're most focused on right now is just the tremendous growth and awareness of what we do. And so I would direct people, if they want to know more and they want to understand more about some of the benefits that real patients have received, and also some of the things that real doctors are considering when they refer patients to us, our website has these testimonials of both physicians and patients. And we have some people that are both, right, that are great stories to look at. And also just you mentioned increasing access to this. And the first part of increasing access is just getting to as many places as possible. So we currently have 13 centers, one of which is a research center, and 12 centers that are normal practices. We're going to be expanding 4 more practices by the end of the year. And then in 2025, we hope to open many more. So we'll have, I would say, anywhere from 25 to 35 of these in the United States by the end of next year. And we'll also be expanding internationally. So we thank all of the patients that have chosen us so far. And obviously, it's important for them to come back on a regular basis to make sure that whatever information they got it's not it's not reassurance that lasts forever. Just like your physical exam that your doctor does, it should be repeated at a regular interval. And but for the patients who haven't chosen us yet, I wanted to let them know that we're coming to a more accessible place. We're coming to a city near them soon, and they can, if they have any questions, either contact us or look at our website for information on that.
Outstanding. I think we'll leave it there for the day. Dr. Durand, thank you so much for joining us. It was a real pleasure to have you on. Extraordinarily interesting work that y'all are doing. I can't wait to see where you take it. Obviously, tremendous growth plans in the future. We can't wait to see what you do next. So thank you again for joining us.
Thank you, Chris. It's been a pleasure.
And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn a little more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's our show for today. And until next time, this is Chris Civitarese wishing you health and good cheer. Take care.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.